Hello, welcome to another episode of Meet the Grid podcast. We're very excited here today to discuss about gastrointestinal cancers and neuroendocrine carcinomas with a great colleague, a friend of mine, Dr. David Zhen. Before I let David introduce himself, I'm Petros Grivas. I'm a medical oncologist in Seattle at Hutch Cancer Center, University of Washington. And I really am very, very happy to discuss with Dave. Dave, tell us a little bit about you and welcome to the Meet the Greek podcast.
Dr. Grivas, thank you so much for having me. It's an honor to be here. I'm one of the GI medical oncologists here. And obviously there's a lot of cancers that we treat within GI, but I heavily focus within gastroesophageal cancers and neuroendocrine cancers. And I'm the director of our neuroendocrine program here.
Fantastic. And that reminds me that actually I call you the neuroendocrine guy and you're calling me the Greek bladder guy.
Yes.
So I want the audience to know, we introduce ourselves with our nicknames here. So Dave, it's obviously a fun story how you and me met, but I'll let you summarize that and also tell us a little bit about your journey so far and how did you end up in Seattle?
Yeah. So I actually did pretty much most of my medical training in the Midwest. Most of that was in Michigan, with the exception I did my medicine residency at the Mayo Clinic in Minnesota. Realized that I missed Michigan, so wanted to go back there, and I did my hematology oncology fellowship at the University of Michigan. Was planning on staying there, had a job in line and everything, but my mentors appropriately told me that I need to explore my options, and that led me here to Seattle, where there was an open position at that time. What I was not envisioning at that time was how much I fell in love with this group. I think what I love about our GI group is just the collegiality. And then at that period of time, I think the resources and kind of mentorship that I needed to build kind of what I wanted to do from a research standpoint in my career and building a program and such, ultimately has led me here to being here now for 8 years. And I love being here. And now I consider myself as a Seattleite and one of our faculty members here.
That's great, David. And it's really great to have you here. And you came here before me. And I have to say, you were one of the first people I met when I came to Seattle, and we did, both of us did our training at the University of Michigan. So we kind of knew each other before, and then we had the opportunity to meet in person. This was in fall of 2017.
Yep, that's correct. Yeah, and I remember when our leadership within the HEMONC had mentioned that, there's this guy we're trying to recruit for GU. You might know him. He had trained at the University of Michigan, and I had heard about Petros for a long time. That's his reputation, right? So even at Michigan, people would talk about him all the time, and it's like, well, I wish I could meet this Greek, person, at some point. And then when I asked them, who is this person that we're interviewing, they're like, oh, it's Dr. Petros Grivas. So it was just a very fortuitous time and just opportune time that this all happened.
I appreciate you, my friend, and it was such a great thing to meet in person. And time flies, and we're here together in Seattle 8 years later. Mm-hmm. I really admire what you have done with both gastrointestinal oncology and the neuroendocrine oncology programs. So let me ask you, David, a little bit about, let's start with the, kind of upper GI tract cancers, esophageal gastric cancer. Tell us, what is like exciting in the field right now, and a couple of things that are very important in terms of research directions.
Yeah, so I think both for gastroesophageal cancers and neuroendocrine cancers, I would say even 8 years ago when I first joined, there wasn't really a lot of momentum. There wasn't really a lot of things changing. And I would say even just, in the past 8 years, but more so, I would just say even in the past couple of years, we've had a ton of new therapies. The way that we treat gastroesophageal cancer as well as neuroendocrine cancer, I think, has changed, meaning that, we use a lot of different specialties, including our surgeons, our interventional radiologists, right? There's novel therapies about how we treat both of these cancers. There's new drugs, immunotherapies, right? But not just our standard immune checkpoint inhibitors, but now we have novel adoptive cellular therapies such as CAR T therapies. We have bispecific T cell engagers. And all of these types of treatments are now coming into play for solid tumors, especially for gastroesophageal and neuroendocrine. And that's where, again, I think a lot of the studies are still early, but that's where it's exciting, is that, one of the reasons I came here is the forefront to be able to oversee some of these clinical trials now that we're doing, and hopefully one day these will become effective therapies for these cancers too.
It's impressive, what has happened in the last, several years. And I really appreciate what you said. For Hutch is in the forefront, doing these clinical trials. Some of them can be practice changing.
Mhm.
It's great to be part of this changing landscape, right?
Yeah, exactly. And I think part of it is, we obviously have the here at the Hutch a lot of the resources to be able to kind of run those kind of studies. But I think at the same token too, what's even I think sets us apart in terms of running these studies is also just, our great teams managing the side effects related to these treatments, both from standard treatments, but also clinical trial treatments, and our infrastructure to really just kind of support our patients along the way through whatever journey that they choose decide to do here.
Absolutely. And, I was talking to our colleague and friend, Dr. Rachel Safian, and she was sharing with us about the amazing work in the GI, meaning gastrointestinal oncology team, and also, the multiple clinical trials you guys are doing. Can you give us a couple of examples, David, of things that, maybe you are involved in and they're very exciting?
Yeah, exactly. So I would say, I think within the GI cancer world, we're moving along the path of, even though, yes, there are nuances that we have to keep in mind for each cancer. They're treated very differently. The biology is very different. We're also at the same token too, trying to come up with therapies that quote unquote are kind of like a tumor agnostic approach. So could we develop a method where we could treat multiple cancers by a unique, let's say, molecular target or molecular therapy, right? And I think a couple of examples I can come into mind. One trial that I'm leading here is a CAR T trial. So as we know, CAR T therapy utilizing one's own T cells to recognize a cancer antigen and then fight cancer that way has made a lot of headway within hematological cancers like lymphoma and leukemias, but in solid tumors, it's been challenging because many of the targets that we choose are also expressed on normal cells. So we end up not only getting anti-cancer activity, but the side effects related to it because it can irritate the normal tissue. So one therapy that we have here is one of the targets is Claudin 18.2, which is a tight junction protein, keeps cells together. We know in stomach cancers and esophagus cancers that these proteins get expressed on the surface of the cells, and so that makes the natural targets. There's already medical therapies, monoclonal antibodies that can target this already. That's FDA approved. But now the idea is, can we use the same target but treat it differently, use it utilizing CAR T cells? And we've actually had some patients with some early responses related to that, some toxicities, but we've been able to manage that. And then I think another interesting area is not only just targeting proteins on the cell surface, but even targeting difficult proteins within the cell. So we actually have trials looking at bispecific T cell engagers, so not necessarily utilizing one cells, but engineering a therapy where we can recognize an intracellular protein, but then pulling immune cells directly to the cancer cells and eliciting one's own immune response to really fight the cancer, right? And I think one novel strategy we're doing is looking at TP53. So we will have a trial that will be opening up pretty soon, looking at a very specific TP53 mutation and looking if we can use this bispecific T cell engager to treat very refractory cancers, including gastroesophageal and neuroendocrine carcinomas.
Wow, that's very impressive. Get to that point of kind of individualized in a way,
Yep.
based on particular molecular features of the cancer, right?
Yep. Correct. Exactly.
And in terms of the screening, Dave, patients may have the classical tumor next generation sequencing, looking at those mutations in any platform, right? Commercial available platform. Is that right?
Yep, that's correct. I mean, there will be some screening that's required by some central assays required by the study, but many of these, for example, like the TP53 study that I talked about, we identify patients through third-party platforms, including, for example, like Tempus, who has a Tempus Aware program, where basically what they do is that they search through their entire catalog of patients who get standard of care next generation sequencing, and if they identify a patient that basically has these mutations, we get alerted about these patients, right? So it increases the chance and success of basically identifying patients for these clinical trials.
That's great, and shows the collaboration, right? With external colleagues, and other companies. And talking about collaboration, one thing that comes to mind, David, is our friends and colleagues in community oncology sites. you and me are working together in organizing CME events and, forums where we can have education and get people together. And it always, impresses me that colleagues in community sites see multiple cancer types.
Yeah,
It's
correct.
right how they keep up all the data together.
Yeah.
It's quite impressive. Any thoughts about how the GI medical oncology team interacts with community oncology colleagues?
Yeah, I mean, we interact with our community oncology colleagues very closely, and I think it's very important to do, right? So, many of the times when we're discussing treatment options with a patient, oftentimes the best treatment is actually still standard treatment, right? And many of our patients don't live in Seattle; they live in very vast regions of Washington, right? Rural areas of Washington, but not even just that, right? They're also within our neighboring WWAMI region, as we call it, right? Our nearby states like such as Idaho, Wyoming, and Alaska, right? So we see a very large range net of patients. And many of the times, I mean, as much as they would love to come here to Seattle, it's just not appropriate without kind of their care. So we need to work closely, right, with our oncologists because that's where the patients are going to have their social support and thrive. But let's say when there comes a time where, let's say, maybe we need to look at alternative options, including a clinical trial option, having that connection is very important because then we can work closely to then streamline the care of those patients and bring them here when it's appropriate. So,
Absolutely. I think you're right. And that, relationship, that dialogue, right, between us and the colleagues in community is so vital. And, we always welcome, ideas from colleagues in community, how we can work together even, more, get patients in right away, to facilitate rapid access. And of course, offer the patients, to your point, when they're able, good access to
mhm.
innovative treatments through clinical trials.
Yep, exactly. Yep.
And there's so many of those clinical trial ideas. And, we try actually to broadcast our clinical trial portfolio. David, we're working on a phone app to make
hmm
it
Yep.
easier for our friends and community. In their phone, they can have this application. They can click, let's say GU oncology or GI oncology. What trials are going on in esophageal cancer, localized disease, metastatic disease, with a contact information there, so they can have a point of contact. And we have, of course, the intake teams with nurse navigators and the schedulers, try to get these patients in right away to help them, of course, and then close the loop, communicate back with oncology community leagues. David, you have done so much work with neuroendocrine carcinoma, such a difficult, cancer biology. You are leading a large phase 3 trial through the SWOG cooperative group. Tell us more about it.
Yeah, so this is a trial. So I think without getting into a very long lecture about neuroendocrine cancers, because the classification is very complicated, obviously we know a lot about neuroendocrine tumors. These are patients that often may have a very prolonged prognosis, slow-growing disease. But the other end of the spectrum is we have what we call extrapulmonary neuroendocrine carcinomas. So these are aggressive neuroendocrine-related cancers that occur outside of the lung. The reason I bring up the lung is because it's a rare disease. We don't really know how best to treat it, but the current standard of how we treat it is we treat it like a type of lung cancer, small cell lung cancer, which is also just a neuroendocrine cancer of the lung. However, I think whether or not that treatment paradigm is appropriate is, I think, remains to be determined. And we also, what we don't know is whether some of the treatments that we use in small cell lung cancer, such as immune checkpoint inhibitors and immunotherapy, whether it has that same benefit. Because I will say the biology of extrapulmonary neuroendocrine carcinomas is very different. And so, these can occur within the GI tract. It also occurs in, prostate as well, too, right? And we just don't know if these therapies are going to be equally beneficial. So the study that I'm leading is a study that's run through one of the NCI cooperative groups called SWOG. And basically, it's a randomized phase 2-3 trial where we're really trying to prospectively evaluate whether the addition of immunotherapy, both with first-line chemotherapy, which usually is a combination of platinum and etoposide chemotherapy, whether we do it with chemotherapy, and then also if patients don't progress of their initial course of chemo, whether we can use the immunotherapy as a maintenance strategy to keep the disease stable for as long as possible, whether that's also beneficial as well too. And happy to report that that trial is over 60-70% accrued. So hopefully within the next year, we'll have some results from that study. So.
That's great achievement, David. That's a milestone, right? To get the trial up and running through a large cooperative research group like SWOG, the NCTN, the National Clinical Trial Network, and getting this study accrued is so important, and asking a very important question. If I can switch gears, David, a lot is being discussed these days about genetic predisposition to cancer,
Mm.
genetic factors, environmental factors. Traditionally we have all looked at that, and with the tools we had, we had, a degree of understanding. But recently, with better technology, gene sequencing, we're getting more and more insights about, genetic predisposition. Could you comment about that? Especially gastric cancer, other GI cancers, pancreatic, for example. We have genetics counseling team here. Any comments on that? How is integrated to the cancer care episode?
Yeah, I think, you bring up a great point. Most of the time, cancers, especially within the GI tract, we don't really have a great reason. It's either, things that might be in the environment or maybe other external factors. But yes, there's a subset of patients in all of our GI cancers where it can be hereditary related, right? And I think there's two implications to that. For some of our cancers, for example, in pancreas cancer, and even I would say even the neuroendocrine, it affects the patient's potential management, right? Because it might open up certain treatments that might not be available to other patients when they don't have the hereditary syndrome, right? But I think second most important is that obviously we always want to try to reduce the burden of cancer in the society. So also understanding if there's a genetic predisposition for that patient is important to inform screening for the rest of their family, right? So yes, so I think it's a very important part, and at least within the GI oncology group, probably likewise as the rest of the Hutch here, is to that we have a very strong medical genetics program, and many of the times when we're already thinking along those lines, for example, pancreatic cancer, it is considered as part of in our NCCN guidelines, national cancer guidelines, that we refer patients right automatically to medical genetics because we often may find a germline syndrome that may exist even in the absence of a strong family history of that, right? And it can really impact the patients, but also families management as well.
Absolutely. So important for the patient and the broader family, to your point, for cancer prevention for both men and women across the broader family and different cancer types, of
Mhm.
course. And we see a lot of young onset colorectal cancer these days. It's kind of a pandemic by itself. Do you think, genetic factors, environmental factors, microbiome, all of the above may contribute to this younger onset colorectal cancer?
Yeah, I think young onset cancers, and you brought up colorectal cancer. I think, yeah, definitely something that we're seeing on the rise. I think what are the underlying causes? I think you've mentioned many of those causes. Is it just one? I don't think it's one. It's probably a combination of various factors and such. But yeah, we are unfortunately seeing a rise in young onset cancers, and I think across the board. And I've seen it in gastroesophageal. I've seen it in neuroendocrine as well too. And I think we have more to learn in terms of what are not only the underlying factors that may drive why we're seeing such a young incidence, but also figuring out is the biology different with these cancers, right? And should we be treating some of these patients differently? And yeah, I think there's a lot of active research in that area.
For sure, the research is really, really important. Understanding exactly the some causes and how can we intervene, right? And
Mhm. Yep.
efforts in the society level to reduce cancer burden, and incidents, and also develop therapeutics. To your
Mhm.
point, through clinical trials and beyond.
Yep.
Talking about multidisciplinary care, I know we have a lot of colleagues working in surgery, radiation oncology, nutrition, so on and so forth. Could you comment briefly about the multidisciplinary nature of the team in GI oncology?
Yeah, in GI oncology, we are a multidisciplinary disease, meaning that many of our cancers requires a lot of specialties to adequately treat, especially when they're locally advanced, right? But even sometimes in rare situations, metastatic or more advanced disease, right? And so these include our surgeons, but we also have our radiation oncologists, we have our interventional radiologists who can treat liver metastases, right? If they're limited, and that's where the bulk of the disease is, and we can want to control disease in patients in that fashion. But then we even have novel therapies that we're doing for liver, right? So, such as the hepatic artery infusions that our colon cancer colleagues are often using, right? So, a lot of multidisciplinary discussions and approach because there's not a one size fits all for many of our cancer patients. And yeah, I would say each of our disease, I would say colon cancer, pancreas cancer, neuroendocrine cancers, gastroesophageal cancer, we have a separate multidisciplinary clinic for each of these cancers, right? So, that takes a lot of time on our parts, trying to run and to, but yeah, it requires a multi-D approach, and that is something that we do very commonly in our GI group.
That is so important, David, to your point, having that multidisciplinary team, people coming together, the experts reviewing imaging, reviewing pathology slides, getting, input from different, players of the team. That's critical for the patient to deliver a customized, personalized care decision-making process. And I think overall, the HATS provides that forum. And as you mentioned, there are different examples of multidisciplinary clinics with real-time review of information, and I think that's very, very important to try to synthesize those types of information and develop a therapy plan. um, David, there, of course, with all the research being done, there are many survivors out there, and we celebrate survivorship, of course. Any comments how this looks like in gastrointestinal medical oncology?
Yeah, I think, there's several different pathways here. Obviously, we have through our gastrointestinal group, so just regular GI, where they have a cancer survivorship program that, some of our patients who may need longer term follow up, I think, particularly are ones with hereditary syndromes that might need further endoscopies and such like that. So our GI group are often, very involved with that. Many of times, I would say also for our long-term survivor, a lot of them are also followed by us, right, in medical oncology, right, and we might need to refer them appropriately when things come up and such like that. But yes, we also follow many of our long-term survivors, and it's great to see that we're starting to see that in GI cancers, because that is something that we haven't seen really much, right? But I think with the evolution of our treatments and better treatment paradigms and such, yeah, we have now a good problem where we're actually following patients for a very long period of time, and needing to follow not the long-term consequences of also the treatments that we're doing.
Absolutely. And seeing more patients alive for longer times with better quality of life, that's a product, of research, science, and of course, a compassionate care, right? And as you said, having more survivors creates the need to have a survivorship program.
Yep.
I was talking earlier today with our colleague, Dr. Vidya Nair, who is leading such an effort for adult survivorship. So I think we're going to have more and more to support these patients in their long-term journey. And David, before we go, I want to get your thoughts about the future. We're moving very fast to have way to go in cancer care and research. How do you foresee in the next, 2 to 3 years in GI oncology? Do you see more use of circulating tumor DNA? I know our colleague, Dr. Stacy Owen,
Mhm.
here in Fairhatch is leading, efforts. Our leader, Dr. Gabi Kiorian, is also doing work in GI oncology. Any comments where we're going?
Yeah, I think two big high principles that I would say is where we're going. Number one, I think still continuing to identify novel therapies, right? And I think novel therapies from the standpoint, for example, as I mentioned before, some of these really novel immunotherapies, adoptive cellular therapies, the bispecific T cell engagers, right? Could we translate this more, right, in terms of treating some really difficult diseases that normally don't respond to traditional chemotherapy, right? But then I think even more interestingly, I think is also the opposite end of it, which is can we think about de-escalating some therapies, right? And de-escalation strategies, because some of our cancers, we have changed our paradigm, particularly in, for example, rectal cancer, where now, with certain treatments, with just chemotherapy, radiation, we can get a complete response. We might be able to avoid surgery and the long-term consequences related to that. Some of our patients have unique molecular markers such as microsatellite instability and the immune checkpoint inhibitors, and we don't even need any chemotherapy or surgery, right? And so now we need to think about strategies about how can we also appropriately de-escalate treatments for patients and still give them the best outcomes as possible, right?
Absolutely. And that decision about escalation versus de escalation is a personalized one. And I think the data from trials, many of the trials we're doing here for HATS, can help answer those very important questions and help our patients, live longer, as you said, and a better life. And, take into account effectiveness of treatment and toxicity as well. David, I can keep talking with you for a long time. I always learn from you. It's great to work with you. When we do CME events together, I promise the audience that you will do a Greek dance one day, and that's still my goal.
One day.
So one day, the audience is listening, so we have
Yeah.
a commitment here. Greek dancing, on the way. So great work. Appreciate all the work you're doing and leading. Congratulations, and looking forward, for more innovative research from your team. And thanks for your time today, David.
Oh no, thank you, and it's been an honor. Looking forward to seeing you again.
Absolutely, and thanks to the audience for watching us. Always a pleasure to interacting with you, and looking forward for more podcasts coming up very soon. Meet the Greek. Thanks so much for all you're doing.